Hi, I'm Joshua Gary. I'm an orthopedic trauma surgeon in Los Angeles, California. The CurvaFix is a new implant that allows us to place implants in the pelvic ring in corridors that aren't straight. It can be particularly helpful in patients with challenging anatomy or in patients where we need transsacral fixation, such as sacral dysmorphs, where we can't place that with straight implants. So we're first going to talk about placement of an anterior column screw or a rod screw in the anterior column. You can see the imaging we use here is what's standard even when we've been using straight implants in the past, where you use an obturator outlet image or combined obturator outlet and then an inlet image. Things that are really important, if we're going to use a straight implant, we really have two constriction points within this osseous fixation pathway. One's in the supraacetabular region and a second here is above the obturator ring. And so with a straight implant, 2 points make a line. And you can see here the pathway we'd have to take with either a retrograde or antegrade starting portal. We have to be extremely precise to have a large diameter screw hit both of these constriction points. And so here our starting point is really limited to about here without much room for play. When we think about a curved implant though, the starting point gets much bigger and much more forgiving. You need much less precision to navigate this corridor and keep the implant intraosseous. When we look at it on the inlet image, which is the other image we tend to use, we can see here the inferior ramus, and then this is the back of the superior ramus. We have to remember that this is not tubular or conical all the way down. The iliopectineal eminence here anteriorly, we have hills and valleys, and so if you're too anterior here, you can actually be in-out in near the structures like the psoas gutter, the psoas, the femoral nerve, and then as you get medial to the iliopectineal eminence, the external iliac vessels as they turn into common femoral vessels. So we typically want to keep this posterior on the inlet image, and then if we're needing to get a screw, if we have a fracture here and we've got to get this all the way into this parasymphyseal bone, our starting point has to be really, really precise. We can end screws or even rod screws out here, but if we have a more medial fracture, we're going to need a starting point here more anterior. That can sometimes cause these implants to be in-out in the psoas gutter or medial to the iliopectineal eminence. With a rod screw, it allows us to start more posterior and curve the implant into the superior ramus and should decrease the amount of times we have that in-out-in pathway for the implant. So we're going to start by placing the CurvaFix in the superior ramus pathway. We recommend an antegrade placement for the CurvaFix for these implants. There are two options. There's a 7.5 millimeter diameter and 9.5 millimeter diameter. The 7.5 is a newer implant and will fit much better in most of the superior ramus pathways. So it's going to allow this implant to be used much more commonly in the anterior pelvic ring. So we'll begin with the imaging that we talked about earlier. You have several different guide wire options. You have terminally threaded, you have fully threaded, short and long. I'll use a long terminally threaded today. Get an image, please. So there I'm too anterior, so I'm just going to move back posterior. And again, like we said, one of the advantages of this implant is it allows us to start more posterior but still get into the parasymphyseal bone of the superior ramus. Can I get an image there? Okay, that will be the image we can start on. Again, that's more posterior than we could typically start with a straight implant. So can we come to the obturator outlet image now, please? It's really important that you get your start point and make sure it's correct in both views before entering the bone. If you make a bunch of holes or pilot passes, it can be difficult to get your start point correct. So we're going to come down to an outlet too, please. So there you can see we are too caudal, but again, with the curved implant, we've got to enter for about 3 centimeters with a straight implant before we can start using the bending devices. So that starting point is definitely too caudal for a straight implant. We could potentially use it here, but I'm going to move a touch cranial. But it demonstrates why you need to have it correct on both views before entering the bone. Get an image there, please. Image there. Okay, that's good. Can we come back to that inlet image again, please? X-ray. Okay, and let's come back to that other image, the obturator outlet, please. I like starting with the wire free. I don't like having the drill bit on the wire. because it allows me to be more precise with the starting point. Image there, please. And then one more time to that inlet image, please. Yeah, image there, please, Jose. Yeah, so that's a little bit more posterior than you do with a straight implant. Sometimes it can be tough to get the wire to go in because this oblique surface, the wire can slip. So you can change the orientation of the wire if the guide wire is in proper position, and then just correct with a drill bit. X-ray there, I think. Okay, X-ray. X-ray there. Okay, can we come back to the outrator outlet image? Just use a scalpel over the wire now. Sometimes an 11 blade can be helpful here too. All right, now there is a soft tissue protector you can use if you want that can go down over the wire and bluntly spread. I'm just going to use the drill bit, but feel free to use this if you want. So here, what we really need to think about is that first 3 centimeters. This is going to be the trajectory. X-ray. Is we can start to swallow the wire and then change the trajectory of our hand with the drill. So X-ray there. If I want to aim a touch more caudal with this, I can spin and etch the pathway. X-ray, like that. Can we? Yeah, and then that roll back straight up and down. That's good, please. Right here we can see these aren't the iliopectineal and ilioischial lines because it's an inlet, not an AP. But if we breach those, we would be out into the intra-abdominal cavity. X-ray. So for this first 3 centimeters, X-ray. 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 And then let's come back to the other view. You can see an etch there on the drill bit, and that will be that 30 millimeter mark for the straight portion of the CurvaFix implant. See there we're above the acetabulum, and you can see we're almost in for the straight portion. X-ray. And there we're in. So now that we have the guide wire in, this is a bent tip steerable guide wire. So we can insert it through one of the straight sleeves. So one thing you can do before you have to recannulate this pathway is you can put this adjacent to your starting wire. It will also keep it through the same soft tissue tunnel. You can also use the soft tissue sleeve. Can I get an image there, please? So here we're close. Can I see the empty wire driver now? Image there, please. Image. X-ray. Tandem shot, please. X-ray. X-ray. And now we're in the pathway. Image there, please. Support this extra point. Just support that. Image there, please. Image there, please. So now we're in, that's that first 3 centimeters. And now you can see we have the flexible implant. So you can see there we can head more caudal away from the pelvic brim and iliopectineal eminence. Can we come back to the other image now? When we get to the inlet image, we want to keep this posterior, just anterior to the posterior limit, because again, that's where you don't have these, where you don't have the hills and valleys near the iliopectineal eminence. So here you can see we're too posterior, adjacent to those lines. So let me turn, image there, image there, image. X-ray, X-ray, image please, image please. So here it's deflecting off of that posterior cortex. Can we come back to the other image please? So when we have this T-handle chuck on the steerable guide wire, you generally don't want more than about an inch between the sleeve and the wire, because the wire is fairly flexible. So you can see here that we're safe in this image, and we'll come back to the image there, please. Okay, let's come back to that other image now. Pull back just towards the midline a little. So you can see now that we've navigated, come a little bit more straight up and down. So here on this image, the superior and inferior rami actually tilt more towards an AP. Yeah, let's separate the rami a little bit. X-ray there. So you want to be able, and this is a nice image compared to the last one where you can see the inferior and superior ramus. So you can see that posterior border of the superior ramus. So we can come just a little bit more, and then we can turn using the, plan on using the curve and the screw. Image there. X-ray there. So now we can make this turn. X-ray. Image. Okay. Now let's come back to the other image. So it's always important to check both views to ensure that when you turn this to accommodate a corridor that you're still heading where you want in the other image. So you can see me doing a lot of tapping and turning. These pathways, once you make a path, even though some parts of this are hollow, it can be really difficult to correct it. So here you can see I'm actually heading cranial. And so once you make a bad path, it's much harder to correct. So that's why it's important to check both images and to use the tapping. So here, if I turn this 180 degrees, it should be pretty close to the same on the other image and change here. Image there. Okay, let's come back to the other image to make sure we're taking the path we want. Isaiah gets his workout today.
Doing great.
Image there. Just a little bit more before we come back to the other. Right, so we want to head that a little posterior right now. We're trying to get under the parasymphyseal ramus. Image there. All right, let's come to the other view. So if we'd been planning on using a straight implant, clearly our starting point wouldn't have allowed that to go down this corridor. You can see how flexible we are, and we're able to start more posterior, which decreases the risk of in-out implants in the front of the ring. Image there. Need to head a little cranial, so turn it the other way. Image there. There we go. Image, please. Image. Touch more cranial. X-ray. X-ray. All right, let's go back to the other view, please. So really getting this first pass right is critical before we ream. Again, we talked earlier about the constriction points above the acetabulum and the obturator ring, and here we're in good position now. Take this all the way down and dock it. Image. Image. X-ray. 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 Sometimes you have to tighten the T-handle chuck on the wire. X-ray to loosen, turn it. X-ray. All right, and let's come back to that other image. But this can be really helpful when you're trying to get these more medial fractures from an antegrade approach. Image there, please. Okay, great, and let's come back to the other view. So you can really see on that image that you may be able to get a straight implant with that starting point, but when we look at this inlet image with the posterior start point, it do not accommodate a straight implant from this starting point. You can choose to or not to take the cortex here. In younger patients, it can be more difficult with this wire to get it through a cortex, but you can get it. Okay. So now that we have our wire where we want, we're going to remove the steerable guide sleeve. And then we're going to use the measuring device. So the measuring device measures, this needs to be inserted into our drilled corridor because it's going to measure just like the head of the screw. And it measures to the ball on the flexible steerable guide rod. Okay, image there, please. Can you push in just a little? Push in just a little bit more and come towards the head of the bed, please. And right now this measures 115. So we could probably take a 110 here. We can come to the other view now to ensure that this is seated on the lateral ilium. And there's where it's not completely down. Image there. Image there. So good to get an obturator outlet image. And now this measures approximately 112. So we do have an option of a countersink that we can use, but we'd probably use a 110 millimeter CurvaFix here. So the countersink is not always necessary, but you can use it. Bring the head of the screw down on any surface. You don't have to use it here. Image there. Image here, please. And so here, as we're bringing this in to get the head of the CurvaFix implant more flat, we will need to remeasure after a countersink comes in. Image. So we can see that. Let's use a measuring device. Image there. And now we're measuring right at just over 110. So we can take a 110 millimeter rod screw. Next step would be the reamer. So these are flexible reamers, similar to what you'd use for an intramedullary nail of a long bone. Image there, please. Great, can you pull back just a little bit? Image. So that looks great. Can we come to the inlet image, please? Just because here you can see we look really good in the corridor, but we know in that inlet image was where we were against the posterior aspect of the superior ramus. And you can see there we're just near that bone. You can tilt a little bit towards an inlet. There you go, right there is good. Yeah, so here I'm just using the 7 millimeter diameter reamer to prepare the path. For the CurvaFix, and you can see it accommodates to our wire. So we ream till the reamer hits the ball tip. Image there, please. Image. Image. Just making sure and you can see the wire backed up just a little. Image. Okay. And next we're going to use our exchange tube. So here we need to exchange the bent tip steerable guide wire for a straight guide wire prior to placing the CurvaFix. If we place a CurvaFix over this bent tip guide wire, we will not be able to get the wire out. Image there, please. So here you can see the exchange tube going down the canal. This can require a little bit of force. Image there, please. And we are down, that you can see on that image there. And now we exchange it. Now we exchange it for the non-ball tips. Here it's not quite getting image there. Let's see if we can get it in that. One thing is we only ream to the ball tip, so sometimes as you get to this terminal path, image there. Image. Let me see. And so here we're having difficulty getting the path we initially reamed, so we can, even with this straight guide wire, put a gentle bend into this. Just at the tip of the wire. Image there, please. Image. 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 Yeah. Image there. And now we're back in the path that we reamed. Image. Image there, please. So you can see it's going to go in that first initial 3 centimeters we drilled. Image.
That's clean.
Image there. Image. Image there. Image. Image. Image there. That should work. Now we could just watch this advance under fluoroscopy. Image. Image there. Here it will deflect off that posterior aspect of the superior ramus and begin to curve. Image. Image. And here you can see it will begin to deflect back into the superior ramus again. Image. So you've really got to think almost in 4 dimensions with the CurvaFix implant instead of the 2 or 3 dimensions we're used to with straight implants. Image. 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 All right, let's come back to the other view just to watch the implant dock. Image there. Image. Image. The links on the implant, because it does lengthen and elongate between each length, approximately 0.6 millimeters, can change. Image there. Because it's not a static length implant. Right, image there. Okay, good. Let's come back to the other view. You can see there we're safe above the acetabulum. One view on a convexity showing we're extra articular and we're in safe position. Image there. All right, image there, please. So now the T-handle needs to come off. This will come in, that will tension the cables and lock. So there, as we tension the cables on the inside or lock the cables, there are 2 lines that will line up here. You want to hold the bends to prevent the CurvaFix from rotating. And now we're locked as the lines line up. Good, and then to uncouple the screw insertion device or CurvaFix insertion device, you can use this to hold this in. You can rotate this and bring it down, and then you can use this to lever back and forth. So once this is brought back, you bring the sleeve back, and then you lever off until it disconnects. Image there, please. For CurvaFix implant is in place.